Welcome, everyone. Welcome to the 10th CITF seminar series, COVID-19 and Older Canadians, Where Are We Now? My name is Dr. Samir Sinha, and I will be your moderator today. The subject of today's webinar is close to my heart, as I'm the Director of Geriatrics at Sinai Health and the University Health Network hospitals in Toronto. And I'm also a Professor of Medicine at the University of Toronto and an Associate and Adjunct Professor of Medicine at the Johns Hopkins University School of Medicine. Before we get started, I've been asked to share some instructions as we are providing simultaneous translation into French, and we'll have a bilingual question and answer period as well. Bienvenue à tous et à tous au 10e événement.
Welcome to our 10th event in the seminar series of the CITF, the Working Group on COVID-19 Immunity. My name is Samir Sinha, Dr. Samir Sinha. I will be acting as moderator today. Before beginning, I have been asked to share a few instructions with you because we have simultaneous translation into French, and we will have a bilingual question and answer period.
Of a globe, so choose off if you are bilingual and want to only hear the live feed. English attendees, you should select the English option so you can hear the question or the entire event in English. The presentation will be in English, but the question and answer period will be bilingual. Au bas de votre écran Zoom, vous verrez l'icône d'un globe.
You'll see in the lower part of the Zoom page the globe icon. If you want to hear, choose source. If you want to hear it from the floor. The presentation will be in English, but the questions and answers will be bilingual.
Veuillez sélectionner votre langue préférée.
Select your preferred language.
Select your language preference now. So I'd like to introduce you to the presenters today, sharing their CITF-funded research. So you'll see that we have Dr. Timothy Evans, Dr. Manish Sadarangani, Dr. Sharon Walmsley, Dr. Zabrina Brumey, Dr. Andrew Costa, and Dr. Alison McGeer. And you can read their titles there as well. We'll go to the next slide. And so our panelists today are living and working in various places across the area of Turtle Island, known as Canada. I'd like to invite my fellow panelists to acknowledge the land they are speaking from today. I'll lead us off and will mention that a few of us are speaking to you from a city now known as Toronto. The land acknowledgement I will now recognize is said on behalf of myself, Dr. Sharon Walmsley, and Dr. Alison McGeer. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. In order of their presentations now, I'm going to ask Dr. Tim Evans to do his land acknowledgement.
Thank you. I'm speaking to you from my place of work at McGill University, which is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Shawnee and Anishinaabe nations. I would like to acknowledge and thank the diverse Indigenous peoples whose presence marks this territory which peoples of the world know gather.
Thank you very much, Dr. Evans. Now to Dr. Sadarangani.
Thank you, Dr. Sinha. So I'm speaking to you from BC Children's Hospital Research Institute, and we operate on the traditional, ancestral, and unceded territory of the Coast Salish peoples, which includes the Musqueam, Squamish, and Tsleil-Waututh nations. And I'm grateful to the lands that I have the privilege of living and working on, and for the lands that all of you are coming from today. Thank you.
Thank you very much. Now to Dr. Zabrina Brumey.
Thank you. I'm joining you today from St. Paul's Hospital in downtown Vancouver. I'd like to respectfully acknowledge that I'm an uninvited settler on the unceded traditional territories of the Coast Salish peoples. They are the Musqueam, the Squamish, and the Tsleil-Waututh peoples.
Perfect. And now to Dr. Andrew Costa.
Thanks very much. from McMaster University, and so we recognize and acknowledge that it's located on the traditional territories of the Mississauga and Haudenosaunee nations, which is within the lands protected by the Dish with One Spoon Wampum Agreement that Samir mentioned.
Perfect. I want to apologize for my French, and I also want to apologize if I mispronounced any of my co-presenters' names. So I'm going to invite them when they're introducing themselves in their talks, just to say those names clearly in case I did not say them well enough, just out of respect for them and what they're going to share with us. So our first presenter is Dr. Tim Evans, and I'm going to invite you to give your talk.
Thank you very much, Dr. Sinha. I'll begin with a disclaimer that I have no conflicts of interest to declare related to the work of the COVID-19 Immunity Task Force. Next, just a little bit of background on the task force, established way back in April 2020 by the Government of Canada with a mandate to catalyze, support, fund, and harmonize knowledge on SARS-CoV-2 immunity for federal, provincial, and territorial decision makers to inform their efforts to protect Canadians and minimize the impact of the COVID-19 pandemic. Next, the task force has supported a number of studies, about almost 120 over the last 2.5 years, and these are distributed across the various jurisdictions that you can see in this map across the country. And 7 of these studies have had a specific focus on older Canadians. Next. The burden of COVID-19 pandemic has fallen disproportionately on older Canadians. By mid-September 2022, people aged 70 or greater in Canada accounted for 82% of all COVID-19 deaths and 50% of all SARS-CoV-2 related hospitalizations. Next, there are a number of reasons why we think older people are more vulnerable. Part of it relates to frailty in older age, which often diminishes protection afforded by the immune system. But it also reflects the reality that with age, there's an increased risk of individuals having not one, but often multiple underlying medical conditions. But in addition to those two factors, there's also the reality that the social circumstances, in particular living circumstances of older people often facilitates spread of infection, specifically those living in communal or seniors residences. So those are some of the reasons. The work, some of the big picture work of the COVID-19 Immunity Task Force has focused on understanding which seniors may be at the highest risk. And what we found is that those living in long-term care residence have had a higher level of seroprevalence, which is due to infection over the course of the epidemic. So this graph shows you that seniors living in long-term care, either the red dots or the crosses, red crosses, that those throughout the various waves, pre-Delta, Delta, and Omicron, the seroprevalence in those settings has been consistently higher than seniors living in other settings. Next slide. We have to understand this also in the context of all age groups. And while earlier in the pandemic, we saw that long-term care residents and seniors had much higher infection, particularly in the pre-Delta waves and the Delta waves, that situation has changed dramatically in the context of the most recent Omicron waves or set of waves. And we've seen that, in fact, older people have had less infection than younger age groups. And this may reflect lessons learned from earlier waves, greater protection, high rates of vaccination, a number of other things. But this is certainly a very consistent pattern, not only here in Canada, but in many other settings.
Thank you very much, Dr. Evans. And now I'm going to invite Dr. Sadarangani to present his team's finding. I'm going to ask him to teach me how to pronounce his name properly as well.
Thank you, Dr. Sinha. So yeah, my name is Dr. Manish Sadarangani, and I'm speaking to you from the University of British Columbia and BC Children's Hospital. And I'm going to talk to you about the Prevent COVID study, which stands for the Prospective Evaluation of Immunity After COVID-19 Vaccines. So these are my disclosure. I have some salary awards, both locally, locally from the hospital and from the Michael Smith Foundation. And I've been working on projects funded by various vaccine manufacturers, but all the funds go to the University of British Columbia. So the study objectives of the study are all on this slide here, but I've highlighted in blue the ones that I'm going to talk about today. And so we set out in this study to look at the immunogenicity of COVID vaccines in adults aged over 50 years, including all of the vaccines that were widely used in Canada during the pandemic. And also I'm going to show you a little bit of information around the influence of prior SARS-CoV-2 infection on vaccine responses. I'm not going to talk about the other study objectives today. So this is the first slide, and I know there's a lot of data here, but essentially this shows the antibody levels. So the higher the horizontal line here in these two graphs, the more antibody there is, and both 1 month after 2 doses, and in the right-hand panel, 4 months after 2 doses. The various groups here, the first two are people who received 2 doses of the same mRNA vaccine. So the red dots are 2 doses of Moderna, and the blue dots 2 doses of Pfizer. In the middle, the green dots are people who received 2 doses of the AstraZeneca vaccine, and then the pink are people who had mixed combinations of Moderna and Pfizer in either order, and then the final group here is people who received the AstraZeneca vaccine followed by any mRNA vaccine. And the main take-home messages from this are that the highest antibody levels were seen with people who received 2 doses of the Moderna vaccine overall. The AstraZeneca followed by an mRNA second dose was very similar in antibody levels to people who received 2 doses of the Pfizer vaccine. And for all of the vaccines, if you compare the same colors on the left-hand panel to the right-hand panel, that you can see from over this first few months after 2 doses of vaccination, there is a reduction in antibody. But overall, these are all very high levels of antibody. And then if we compared the people, we separated out people who'd been infected before their vaccination to those who had not been infected. And the 2 horizontal lines and the dots on the first 2 lines show the people 1 month after their second dose. And then the second set here are 4 months after their second dose. And essentially, while there are more people in the non-infected group, the first half here, the higher antibody levels can be seen in people who had prior infection. And when we looked at other determinants of the vaccine response, we found that whether we looked at 1 month or at 4 months, so people who were infected had higher antibody levels, people who received 2 doses of Moderna had higher vaccine antibody levels, and people who had an interval of at least 14 weeks between their 2 vaccines had higher antibody levels as well. And you'll recall that as the rollout happened, the interval changed over time. Interestingly, and I'll briefly mention this, at the 4 month point, we also saw that males had a slightly lower antibody level than females. And now just moving on to looking at booster vaccines. And so 3 panels, slightly different colors. And I think for this slide, the colors really and the different groupings don't matter. Obviously, it gets a little bit more complicated with the different combinations that people could have had by this point. And it shows you 1, 4, and 7 months after the booster dose. And essentially, I think the main take-home message from this is that those differences that we saw after 2 doses are very, very small at this point. And so those mRNA boosters were very effective in boosting antibody levels with whatever the combination of the first 2 doses was, and the durability of that response out to 7 months after the booster is maintained much better than it is after 2 doses. And then as a final comment, one of the things we did also want to look at is comparing this group against a younger adult group. And so we, as I said, the overall cohort, our main cohort was over 50 years. The average age was around 65, and we had people up to the mid to late 80s. And then we recruited a small control group of individuals who were younger than 50 years of age, and essentially found no significant differences in their antibody responses after 2 doses, which was very reassuring for us to see in this group of people who are living in the community who are over 50 years of age. So the main conclusions, so the mRNA vaccines had higher antibody responses than AstraZeneca after 2 doses, particularly Moderna. Differences after the booster were minimal. I think I just want to highlight that there's no known antibody level that correlates with protection. We've seen data from Canada and elsewhere that the mRNA vaccines give higher effectiveness against symptomatic disease, but all 3 vaccines have been similarly effective against severe disease, hospitalization and such. The antibody, I haven't shown you the data today, but we've also been looking at the function of these antibodies, and the antibody amount does correlate with some functions, and this may be important in protection against disease. Prior infection and longer interval has led to higher antibody responses, and sex may also be an important determinant. And I think the other piece I just want to mention is all of these participants gave us samples through finger prick and sending them in the mail. And I think this is a really useful methodology for collecting samples from people for future studies that can be used in even rural and remote areas of Canada. Thank you.
Thank you so much, Dr. Satarangani. We will now turn it over to Dr. Walmsley.
So thanks, Samir. I'm an infectious disease specialist at the University Health Network, and I'm going to share with you some results from our study that's called Stop COVID. Next slide. I have no conflicts of interest related to this study. So we had a similar study to the one that you've just heard about. Ours is also a decentralized study, which follows people. Our older cohort were 70 plus, and we were comparing them to a group who are aged 30 to 50. On the left-hand side there, you can see a copy of our website. And this is the way by which people enrolled into the study, did their consent, and followed their study procedures. You can see that our study population, which is represented by the black dots, did reflect people from across Ontario. And again, this whole decentralized study did allow people to participate who lived in rural areas outside of research centers, who normally may not have the opportunity to participate in research, or perhaps have more mobility or other health issues that would not allow them to travel to a study center. We oversampled for our older population, so we had 853 in the 70 plus group and 340 in the younger group. And the individuals did their consent online. They completed questionnaires about their background characteristics and did 7-day diaries around each of their vaccine doses. People did a check-in every month where they told us whether or not they had further doses of vaccine, whether they had any adverse events, or whether they developed COVID. Their schedule of activities is in their portal, and they were received email reminders every time they were supposed to do a study activity. And we also were able to share the individual and group results with people through their portal. So like the previous study, we did this through dried blood spots, and we had videos on the website to guide people on how to collect these specimens. Next slide. So this is our baseline population, and as expected, there were some differences between the younger and the older group. Our average age in our older group was 73. The average age in the younger group was 41. We had more women in the younger group, and we had more whites in the older group. As anticipated, the older group reported more comorbidities, with about 15% with diabetes, 48% with cardiovascular disease, which was largely hypertension. 20% had reported a previous diagnosis of cancer. Similar to what happened in Vancouver, there were some mixing and matching of the various doses so that the older cohort were more likely to have received 2 doses of Pfizer, whereas the younger cohort were more likely to have received 2 doses of Moderna or a mixture of the AstraZeneca and an mRNA vaccine. Again, over the course of our study, there was a lot of moving around in terms of the timing between the vaccine doses. And the younger cohort received them on average 8 weeks apart and the older cohort 11 weeks apart. Next slide. So these are some of our results. And again, I'm going to show you the antibody response to the RBD, which is on the surface of the virus and is thought to most closely represent neutralizing antibody. We've divided it into individuals in the 2 age groups, and along the y-axis, you can see the various time points over the course of the study. We've also color-coded how many vaccine doses the individuals have had. So if you go to the far left side of the graph, the dotted line represents detectable antibody. And you can see that before the second dose, although many of the younger cohort did have detectable antibody, only half of the older population had detectable antibody at that point. And you can see that at 2 weeks after the second dose, the amount of antibody increased dramatically in both of the cohorts, reinforcing that 2 doses are essential for a vaccine series. Over the next 2 time points, which is 12 weeks and 24 weeks after the second vaccine dose, you can see that the levels of antibody were always higher in the younger cohort than the older cohort, but did decline in time in both groups. You can see then the antibody levels rose again quite dramatically with the booster dose and now have remained elevated over a 60-week period, with the difference between the younger cohort and the older cohort very minimal, although more of the older cohort have had their 4th and 5th doses than the younger cohort. The other thing I want to bring to your attention is if you look at the 60-week point, you can see that all of the younger cohort are above the immunity threshold, whereas for the older cohort, there is quite a tail in terms of the immune response, with a number of individuals not responding as well as a younger group. Next slide. Also, as part of our study in January of this year, we did a test to look at breakthrough infection through the use of rapid antigen tests. And 806 participants in our cohort agreed to participate in this sub-study. And what they did is a home rapid antigen test twice a week and answered a diary once a week about any potential COVID symptoms. Over 90% of patients completed at least 1 test, and in total, over 7,000 rapid antigen tests were performed over the 2-month period. In total, 25 individuals, or 3.4% of this population, did develop a positive rapid antigen test. All of the cases were mild, and 20 out of the 25 had had their booster before having the breakthrough infection. Of these, this was confirmed by the development of antibodies to nucleoprotein, which is another antibody that we measure in the lab and indicates the presence of natural infection. We were trying to determine if we could find a threshold level for immunity, but clearly we had so few cases that we could not find a difference in the antibody levels between those who did and did not have a positive rapid antigen test. We also looked at all of those who did not have a positive test, who reported 1 or fewer symptoms or more symptoms that would potentially be related to COVID, and then we're able to determine a false negative rapid antigen test of 4 to 6%, demonstrating that these tests really perform very well in terms of picking up disease in an elderly population. Of note, our incidence of breakthrough infection is quite low and much lower than the average Canadian numbers that Dr. Evans showed to you at the beginning of this presentation. And we don't know why. And we don't know if that's because our cohort has been so aggressive about receiving their vaccines and their boosters, or whether it has something to do with behavior and following public health protocols. Next slide. The other way that we have been looking at breakthrough infections is either the development of positive nucleoprotein over their dry blood spots, having reported a rapid antigen test, reporting they had infection in their baseline values. And you can see that on average, we have anywhere between 5 and 60 cases of COVID that have happened each time period. And the time periods there reflect the different waves of COVID infection, with the peak really being in April and June of this year, which was during the Omicron B.4/5 wave here in Ontario. But again, I want to bring to your attention that the number, although the absolute number of infections is higher in the older group, remember that we have way more older patients in our population. And so the percentage is actually double in the younger population than it was in the older population, again, showing that they have been protected from disease. Next slide. So I'd like to stop by acknowledging the rest of the Stop COVID study team that I've demonstrated on this slide. I thank you.
Thank you very much, Dr. Walmsley. And now I'm going to invite Dr. Brumey to share her slides in her talk.
Thank you very much for the opportunity to share some data today from our cohort in Vancouver, BC. Can I get the next slide, please? I don't have any conflicts of interest to declare. Next. I'm going to be sharing some slides today that depict younger adults. And when I say younger, I mean, you know, an average of 40 years old or so, always in blue on the slides, and a group of older adults, on average almost 80 years old, in orange. And our group of older adults includes individuals living in long-term care, as well as older adults living independently in the community. We've been following this cohort since December 2020, and I just wanted to show some highlights today. So the first important piece of information that I'd like to share is that we found that it actually took 3 COVID-19 mRNA vaccine doses for antibody levels in older adults to reach equivalence, finally, to younger adults. What we had seen is that after 2 doses, as you can see on the left of the graph, the amount of antibodies in the blood of the older adults, shown in orange, were not as high as those of younger adults. And you can tell that because the orange blob is underneath, lower than the blue one, and the brackets at the top with 2 stars indicates that that difference is statistically significant. After 3 doses, though, everyone gets a boost of about half a log with respect to the amount of antibodies in blood. So we see everyone is boosted up, and then you see that the older adults and the younger adults are equivalent. The two violin plots are next to one another, with the difference not being significant anymore. That's what's indicated by the NS. If I could get the next slide, please. What we know, though, is that after vaccination, naturally, the amount of antibodies in the blood will decline over time, and that will happen after every booster dose. And what's shown here on this slide is that indeed, 3 and 6 months after the 3rd vaccine dose, we are seeing the levels of antibodies in both younger adults as well as older adults decline steadily. The good news is that the rate of this antibody decline, at least in terms of the amount of antibodies in the blood, is comparable in elder and younger adults, because you can see that the orange and the blue violin plots kind of track with one another. But the decline is substantial, and it's to the point that 6 months after the 3rd vaccine dose, the antibody levels in both younger and older adults have actually on average declined to levels that are lower than what we initially saw after 2 doses. Now, all the data that I've shown up until now are individuals who have managed to remain COVID-19 naive throughout the entire amount of follow-up. But what we recently saw in the last few months is that Omicron came, and more than half of Canadians got their first COVID-19 infection after they had received a 3rd dose. So if I could get the next slide, here I'm showing what happens to the amount of antibodies in someone's blood if they get 3 vaccine doses, and then after that have their very first COVID-19 infection. And what we can see here is that that gives a big boost to the amount of antibodies in people's blood, and that is true whether it's older adults or younger adults. In fact, people who got their first COVID-19 infection after their third vaccine dose, 6 months after their third dose, their antibodies are actually still higher than they were right after the third dose, meaning that having a combination of vaccine, antibodies from vaccination, followed by antibodies from a natural infection, gives this hybrid immunity that is stronger and more robust than from vaccination alone. If I could get the next slide. What I've shown so far is the amount of antibodies in somebody's blood after vaccination and or infection, where those antibodies are specific to the original SARS-CoV-2 strain. Unfortunately, the original SARS-CoV-2 strain is now extinct around the world, and what we have now is Omicron. So what I'm showing here on the right side of the graph is the same data, but showing the levels of antibodies against Omicron, the BA.1 strain of Omicron. The trends are the same, but the important thing is the levels of antibodies that are specific to Omicron are much, much lower than those against the original vaccine strain. Next slide, please. The slides that I just showed looked at the amount of antibodies in someone's blood, where generally more is better, but we also have to look at the function of those antibodies as well. What I'm showing here is the function of these antibodies, meaning their ability to neutralize or block infection by the Omicron BA.1 variant. And to do this, we're doing live virus assays in a biocontainment laboratory. I'm showing again the level of neutralization 1 month after the second dose. That's on the left. There you can see older adults don't neutralize as well as younger adults after 2 doses. 1 month after the third dose, everyone gets a boost. And adults, younger adults and older adults now reach equivalence in their ability to neutralize Omicron, although you can see that quite a few individuals of all ages still have neutralization levels that are lower than the minimum ability for us to detect. And sort of the worst news after that is that this ability to neutralize, again, naturally declines over time. In fact, in people who have had 3 vaccine doses but have never had a COVID-19 infection, by 6 months after the third dose, 56% of younger adults now have undetectable ability to neutralize Omicron, and 96% of elder adults have undetectable ability to neutralize Omicron. So this, in concert with the other results from antibodies levels, indicates really that 4th doses will be needed within 3 to 6 months, particularly in older adults, many of whom have already received these. Next slide, please. But again, those individuals who had 3 vaccine doses and then unfortunately acquired a SARS-CoV-2 infection, we see a big boost in the ability of antibodies in their blood to be able to neutralize Omicron BA.1, showing that a silver lining of this hybrid immunity is a better magnitude and more durable immune response. I think I have 2 more quick slides. The next one. I've mentioned that the wild type virus is extinct around the world, and I showed some data about Omicron BA.1, but to be frank, that one is also extinct. Right now, we're looking at Omicron BA.5 as the dominant variant, with some other emerging ones coming next. So we're also interested in asking the question, well, how well do these how well does vaccine and hybrid immunity protect against Omicron BA.5? Unfortunately, what we are finding, and others as well, is that the ability to neutralize Omicron BA.1 is not as good as that of the original wild type strain. And unfortunately, the ability of vaccine induced antibodies to neutralize Omicron BA.5 is worse than that of Omicron BA.1. And here I'm showing data from both younger and older adults 1 month after receiving 3 vaccine doses in individuals who have never had COVID-19. So the good news is that older and younger adults are equivalent, but the bad news is that it doesn't matter who you are. In general, ability to neutralize Omicron BA.5 is not as good as BA.1. And the last slide, I just wanted to share what happens in individuals who have had 3 vaccine doses and then who have experienced their first COVID-19 infection. So here's the same group, but after they have they have experienced their first COVID-19 infection, we can see everyone gets a big boost to all types of neutralization. But again, the ability to neutralize Omicron BA.5 remains poorer than that of Omicron BA.1, which is in turn poorer than the original vaccine strain. This does support the current rollout of bivalent vaccines, but indicates that for vulnerable individuals, maintaining additional precautions like masking will also be important. And finally, I would just like to acknowledge the large study team here in Vancouver, but also to the clinics and above all to the participants without whom research would not be possible. Thank you.
Thank you so much, Dr. Brumey. And we'll now invite Dr. Costa to tell us, please tell us about your team's findings.
Thank you, Samir. I'm pleased to bring some information from our study at McMaster University, the aptly named COVID and long-term care study. I lead the study with Dr. Don Bowdish, who is a noted immunologist in the area of aging as well. We run a fairly large study. It is a study that is enrolled just over, at its peak, 1,100 individuals living in long-term care as well as retirement home or assisted living settings. And we're following those residents in a longitudinal fashion with some replacement of residents, now at about 733 residents in our study. And 2/3 are from long-term care or nursing homes, as they're generally called around the country, and about 1/3 from retirement homes, or what's also known as assisted living settings, which are usually private, for-profit, or subsidized congregate living for older adults. And I have no conflicts of interest to declare. Vaccine uptake, as folks I'm sure are aware, is quite high. And so too it is in our study, where when we look at the first dose, second dose, obviously third and fourth, we have very high vaccine rates, not as high as we'd like in long-term care staff that has been reported, but certainly quite high amongst residents. We see that as well in retirement homes, which is a bit of a different demographic than nursing homes, which is obviously very positive. And right now, most of our eligible participants that are eligible for a 5th dose are starting to receive it, and those data are coming in. Next slide, please. But we still see a lot of infection pressure. And you've seen that in Dr. Evans' slide, other information that's been presented today, likely in the media, and across long-term care homes, although certainly among long-term care nursing homes, more so than retirement homes for a variety of reasons. We see tremendous infection pressure, where in our study, at the height of a recent time in July of 2022, in a single month, about 20% of our participants were infected. And we see complex infection histories, and that's demonstrated on the right, where we see lots of residents who have 2 or more infections and of different types, which contributes to the complicated picture and contributes to the complicated picture of trying to understand how previous infection influences future infection. Why we're seeing so much infection is multifactorial, but hopefully we've illuminated and will continue to illuminate some of those factors. Next slide, please. Should be noted, though, that even though infections are increasing, we're seeing substantial decreases in case fatality. However, I've heard in reports some people describing COVID-19 as now much like the flu. It is not like the flu. It is orders of magnitude more dangerous. And so people should be aware of that. When we look at the picture of, as you've seen, neutralizing capacity of antibodies, we can compare it on the left for the ancestral variant, which of course is, as was mentioned, extinct, and Omicron, in this case, represented by BA1 on the right-hand side. Here we look at post on the bottom, post third dose and post fourth dose for those two pictures. And we look from time from those vaccinations. And what we're comparing is the ability of antibodies to neutralize. And individuals are represented by the bubbles and the median neutralizing capacity by the colored lines. And what you see, if you're looking from left to right on the two big pictures, is that when we compare to let's say the old variant to the newer variants, our vaccines perform substantially less well in the newer variants, which is obviously why we're seeing, part of the reason why we're seeing much more infection in long-term care and retirement spaces. And so that's part of the picture. If you look just then on the right and focus your attention there, you'll see though that picture is true, that we're seeing less performance of the vaccines generally, that more vaccines, in this case, the fourth dose, was very helpful in supporting increased neutralization capacity. Although overall, at all these pictures, we do see a degradation in protection over time, which we've seen again and again, and it is obviously a feature of the pandemic that we continue to see. And so fourth dose matters. This confirmed by more real-world studies in Ontario, where the fourth dose has been shown to be very effective. Next slide, please. The role of previous infection is mixed in our study. And here we're looking at post fourth dose, and we compare the ancestral variant to Omicron, in this case represented by BA1. And we look again at neutralizing capacity, and we divide it up by those that had no infection, which is on the left-hand side, those that had infection prior to Omicron, and so presumed prior to December 15, 2021, prior to Omicron and an Omicron infection, and an Omicron infection on its own. As you can see, it is quite a complicated picture and pattern where there's no easily discernible pattern in terms of previous infections inferring increased immunity and protection in terms of neutralizing capacity. And in fact, across all pictures, we see degradation over time, representing that though there is evidence around the role of previous infections around short-term immunity, that it is complicated, I think, and mixed and short-lived. Next slide, please. And there's lots of curious interactions occurring, particularly now. And so here is a view of a more recent view looking at BA5 infection in our cohort. And here we look at the influence of past infection history on the risk of future infection from a period of July 1st to August 25th. This accounting for just about 800 long-term care residents and retirement home residents. And we find a complicated story, which is that in a lot of epidemiological research, we find that past events predict future events. And here too, we find it now in the BA5 period with respect to infection, where we see that a past history of a recent infection, in this case, a BA1, BA2 infection, increases the risk of a future BA5 infection. Now, that's not necessarily due to the infection, and we're teasing this out now. But with restrictions lifting or having been lifted in long-term care settings, and there being various interpretations of protection and various policies across our homes and indeed across the country, we're starting to see factors of risk that are behaviorally oriented starting to, once again, as it was initially in the pandemic, starting to influence the risk of infection, which is complicating the picture. And so, but for those that were never infected, we see less risk in the BA5 period. Again, I think this has a lot to do with the facility and the risk associated. Next slide, please. Thank you. This is some information from something that we recently released, or fairly recently released. This looks at from December 15th to May 3rd in the early Omicron picture, the hazard associated with infection for BA1, BA2. And what we found, consistent with other evidence suggested today, was that Moderna outperforming Pfizer, so 3 doses of Moderna, outperforming 3 doses of Pfizer. For a fourth dose, we're seeing very, very strong evidence, as has been demonstrated elsewhere, for protection. And again, we see mixed, but what looks to be more than likely to be protective effect of a past infection in the previous 3 months. And so a mixed picture, because the intervention of a vaccine is obviously more precise an event than an infection, among other causes. Next slide, please. And so overall, we tend to think of protection in terms of packages of protection. And so certainly additional doses count, and individuals who are eligible for a dose should certainly receive it. That's obviously the best evidence for protecting yourself and your loved ones. And it looks to be, you know, our evidence is in line with other evidence around the protection associated with vaccine for 3 to 6 months, post-vaccine for infection about 3 months, recognizing that you need to survive the infection in order to receive the benefit if it exists, and that being mixed. It's important to vaccinate at the start of a wave as best as we can time that. I think we have good evidence out of Ontario for the fourth dose, and being done early in Ontario. That it wasn't early in other jurisdictions suggests that it probably should have been, I think, given its performance in Ontario. It's important to get infected as few times as possible. There are risks, we know, in the other evidence around future outcomes as a result of being infected. And of course, the protection that people infer around being infected, you have to survive in order to receive it. And that's not always the most likely. And so protection is the strongest after vaccination. And that should be the goal, I think, for individuals when they think about the availability of different bivalent doses, that it's important to get the one that's available to you versus being choosy. And that's very much in line with all the evidence to date. So thanks very much from us in our very large study, which we rely on a lot of individuals to carry it out. And next slide shows our partners who are very instrumental in our work. Thanks very much.
Thank you very much, Dr. Costa. And now I'm going to pass it over to Dr. McGeer.
Thanks very much, Samir. And welcome, everybody. I'm talking to you from the University of Toronto, as Dr. Sinha said, for the investigators of the immunogenicity sub-study of the Wellness Hub, which is a larger study of infection prevention in long-term care homes. Next slide, please. I work with a large number of vaccine companies and some of the companies that make antivirals for COVID as well. Next slide. So this is a study cohort that's very similar to the McMaster study cohort, except that it does not include retirement homes and it's smaller. So 203 residents enrolled in 4 long-term care homes. And they got a mix of Moderna and Pfizer, with 2 homes getting Moderna and 1 home getting Pfizer in the initial. 3rd dose, same as the 1st dose. And then for the 4th dose in Ontario, everybody in long-term care got Moderna for the reasons you just seen on the past slides. The Moderna is more protective in older adults against COVID-19. The resident characteristics here are fairly typical of long-term care homes, median age of 88 years, a majority of females, and only 8 of the residents are immunocompromised in this cohort. At the start of the study, just before the first doses of vaccine were delivered in January 2021, 25 residents had prior laboratory confirmed cohorts, so no large outbreaks in these homes before. Next slide. Antibody concentrations for the study are measured by ELISA in Dr. Anne-Claude Gingras' lab, by pseudoneutralization, and by viral neutralization at the National Microbiology Lab. And you can see the standard follow-up that is true of all of these studies, with dosing after vaccine at 2 to 4 weeks so that you get peak antibody levels, and then timed after that to look at when we should be thinking about timing next doses of vaccine. Next slide. Okay, so I'm mostly going to talk about some things that are the same, some things that look different but are not actually, and some things that are distinctive about our cohort. Here you see COVID infections in this group of patients. The red are the infections that occurred before the start of the study. Yellow is a gamma outbreak that occurred in one of the nursing homes after 2 doses of vaccine. And then there were no infections until the Omicron wave started. You heard Dr. Costa say that that we started early with the 4th dose in Ontario and that the 4th dose worked well. But in fact, you see that we were actually not early enough with the 4th dose. And this large number of purple infections are Omicron infections that occurred at the end of December and in January, the start of the BA1, BA2 wave in our long-term care homes before we were able to deliver 4th doses with them, just a marker of how quick you have to be in long-term care to protect residents. And then very few infections in the BA1, BA2 wave after 4th doses were given and taken effect. And in fact, one of the best things about that was seeing how high antibody levels were after 4th doses in long-term care. As Dr. Brumey has pointed out, it takes older adults and long-term care residents longer and more doses of vaccine to achieve very high antibody levels, but it still happens. Another important thing to look at here is that, to remember as we go forward into the fall, is that despite the catastrophe that has been long-term care homes and the number of deaths in long-term care homes, 50% of our cohort has not yet been infected with COVID-19. And that's through up to the beginning of the BA4, BA5 wave. So there's still a large number of long-term care residents who going into this fall need to be protected from COVID. Next slide. All right. So this are slides you have seen. Again, you see here the difference between Pfizer and Moderna, with Moderna getting you high antibody levels and with really good antibody levels post-dose 3 on the right side of the left graph. But you also see what happens with Omicron BA2, where antibody levels against the original wild type strain look great after dose 3. But when you look at them against BA2, suddenly you see that many residents do not have neutralizing antibodies against BA2. And this is why 4th doses were so important in protecting residents from infection during the BA2 wave. Next slide. You've seen most of this before. These are in our cohort factors that are associated with pseudoneutralization titers against Omicron post-dose 3. Again, you see the effect of sex. Men do have somewhat lower antibody levels than women. You see it in some studies, but not all, because the difference is small. People who are immunosuppressed in these very frail older adults, even minimal degrees of immunosuppression, have a very sizable impact on antibody production. Pfizer is not as good as Moderna at generating antibodies, and having had prior COVID results in higher antibody levels. Next slide. Now, lastly, looking at what happens with 4th doses of vaccine. So this is pseudoneutralization titers taken 6 months after the 4th dose of vaccine. In this cohort, essentially everybody in our cohort, I think there are 3 residents who haven't had their 4th dose. And you can see that against wild type, there are very high neutralizing antibodies maintained at 6 months after the 4th dose of vaccine. And that's really promising, because what we saw with 2nd doses and 3rd doses was that you did not maintain those high levels of neutralizing antibodies, even against the ancestral strain. But you can also see here that 6 months later, concentrations have dropped very sizably. 22% of residents in August had no neutralizing antibodies detectable against BA5, and another roughly 15% had levels here. A log base 2 here roughly corresponds to what we think are protective antibody levels, and there's another 15% of residents who are very close to that line. And that, of course, was 2 months ago. and we're expecting those to go down again. So this tells you why it's so important that we get a 5th dose of vaccine into long-term care residents this fall before we face increasing COVID activity and are looking at infections in the at least 30% of residents who have not yet been infected in long-term care. And then finally, in this group of residents, a COVID infection during Omicron was the best predictor of high levels of neutralizing antibodies measured 6 months after vaccine, which is kind of an interesting maybe difference between what Dr. Walmsley's study saw, which is that you don't measure higher antibody levels in people who've just had an Omicron infection. But it looks like maybe those antibody levels last longer if you have an infection. So that's another really interesting piece that needs to be teased out as we try to move forward with understanding immunity in residents of long-term care and knowing what the best vaccine program for them is in the coming months and maybe years. And we'll just go to the next slide. This is a very large study team at multiple hospitals and at all 4 of the nursing homes. And I'm grateful for all of the people working on this and all of the residents and substitute decision makers who've been part of the study. Thank you.
Thank you very much, Dr. McGeer. These were terrific presentations and a lot of information. And I'd like to now start our panel discussion. So what we're going to do, folks, is we're going to start with a few questions, just about 2 questions to our panel. And then we have a number of questions that have come in via you. So we'll get to as many as we can soon. So I'd like to start by first of all, just recognizing that that in the seminar we wanted to answer a few questions. So you've answered how important are boosters for those age 70 and above, and I think the answer from what I'm hearing is that from all of you, you're saying that it's very important. We've also answered the question: is the risk of getting COVID-19 higher if you're living in a long-term care home or if you're 70 and older living in the community? And I think the answer that I heard clearly was those living in a long-term care home have been more at risk throughout the pandemic. But as we just heard, that not everyone who's been living in a home has gotten that. And so there's important work that we need to do in all settings. So the first question I just want to ask, and anybody is welcome to maybe answer this question, is right now I think people are thinking about the fall season coming up and hearing about a new wave of COVID infections and a flu season that may be upon us as well. So should older Canadians be masking and distancing and limiting their social interactions indoors? Any general advice that you'd give for those who are worried about wherever they're living, what they should be considering right now?
You want me to walk out of this thin ice, Dr. Sinha? So the first thing that I think older adults need to know is that you want to get both an enhanced flu shot and your booster for COVID before you go into the season. That provides you with really substantial protection, maybe not forever, but for the next few months. After that, yes, I do think it makes sense for those of us who are older adults and are still at some risk. Remember, you know, in Canada, there are still, in Ontario, 50 people dying a week of COVID. And generally speaking, they're frail and they're older. And none of us like to think of ourselves as frail and older, but some of us are. And so, you know, the frailer and older you are, the more you want to think about what things you can do to protect yourself that interfere in the least way with the kind of life you want to live. Okay, so wearing a mask is not that bad. Social distancing is okay. You know, maybe just cutting down on how many restaurants you go to. So thinking about how to maintain protection for older adults, I think, is a really good thing. And all of us have to try to find that balance between being able to live the life that we want to live and still wanting to maintain protection against COVID. It's really obvious from Sharon's study, for instance, that lots of people are still working really hard at protecting themselves from COVID and successfully, right? So there really is a lot of small things you can do to make things better.
Perfect, thanks. Anybody else want to weigh in, or I can get to the next question?
So I think that's kind of our hypothesis is, you know, we've had way more infections in our younger cohort than our older cohort. And our assumption is that the older people are more concerned and therefore more likely to mask and more likely to avoid large crowds. Whereas the younger group, you know, life has kind of gone back to normal. And I can't help but think how many meetings I've been at in the last couple of months with large groups in small spaces where you get that email, oh, by the way, I got COVID, and you know, it happens. And so I agree. I think, you know, the subway, I'm really quite surprised how few people are actually masking on the subway. And you know, that's a really simple thing to do. And that's a closed space and is an element to protect yourself.
And you can see in some of our other studies that people who say they're protecting themselves, people who report less activity and less exposure do have lower rates of infection. So it really is true that masking and distancing and being careful protects you from getting infected. Not 100% of the time, but enough of the time to matter.
And
what I'm hearing, go ahead, Dr. Evans. Yeah.
And just from a very big picture, macro perspective across the country, even in the context of the Omicron tsunami that we've seen, there's still about 10 to 11 million Canadians who've not been infected. And they cluster in the older age groups disproportionately. And so I think the messages that you're hearing from Dr. McGeer and Walmsley and others are absolutely essential. Continuing vigilance and avoiding infection if possible is absolutely critical, especially what we're learning about long COVID and other complications associated with infection.
Perfect. And I think what we heard loud and clear is that the one thing that we can do is with flu and this new wave and boosters available, that it's probably a good chance to get both of them as soon as possible. Perfect. Okay. Then the other question I have, maybe to some of our folks like Dr. Costa who are working in the long-term care space and Dr. McGeer and others, is right now we've seen a lot of infection prevention and control measures implemented in our long-term care and congregate care settings due to COVID. And do we think that this will have a long-term positive impact in warding off other infections in these settings as well? What have we learned so far?
Allison, would you like me to start?
Yeah.
Okay.
Yeah, go.
Okay. I think they have to have an influence. They had an influence, obviously, in a very fast-spreading, pathogen like SARS-CoV-2. They certainly had an influence in the beginning, prior to restrictions and after restrictions, before there was a vaccine. And at least what we're finding now, and it's a more complicated story, post-vaccine, and we have residents in long-term care homes have a lot of the same vaccine picture. There's a lot of uptake, a lot of the same vaccines. What we're seeing as the important elements around future infection is looking like factors associated with the home. We can't tease out exactly what those factors look like because on a home level, they can look very different but it seems like at a home level, there's a lot of action, which suggests that there's still a lot of things that people can do behaviorally and otherwise to prevent infections without going back to some of the more restrictive elements of isolation.
Perfect. Dr. McGeer, did you want to comment as well?
Yeah, I think it's a two-part thing. I do think we've learned a lot about how to reduce the risk of infection in congregate settings. It's also, however, true that many of those things are relatively expensive and restrictive on activities, so we don't want to do them. So it's a two-part thing. I do think there are a number of things we can be doing that will allow us to do better in long-term care, but our fundamental structural issues about crowding, about the number of people in a room, about the size of our long-term care facilities, those are things we need to change too. Because if the COVID pandemic started tomorrow, if the next pandemic started tomorrow and it was respiratory infection, we would not be better off in long-term care than we were at the beginning of this pandemic. We would be better off in the sense that we would know it was coming and we might be willing to do other things, but our risk of transmission would actually not be significantly different, even though we've learned a lot and we're doing better. So there are a large number of fundamental structural and practice issues that also need to change.
To Dr. Gregor's point, just to add to that, we absolutely know now, because of Evidence Ontario that a colleague of ours led, that previous outbreaks for all other respiratory illnesses that are tracked in a similar manner to how COVID outbreaks have been tracked are influenced by structural characteristics like crowding to the exact same degree.
Perfect. Okay, we have a bunch of questions from our audience, and so I'm going to try and get through as many as possible. So this first one is to anyone. Is it possible to have COVID antibody levels drop to 0 for anybody who has either experienced COVID infection or received any of the vaccinations?
Yes, so I can tell you that it's a very small number of people. But we have 2 immunocompromised long-term care residents, one of whom does not have detectable neutralizing antibody 2 weeks after a 4th dose of vaccine. So there are some very frail, compromised people who don't develop antibodies. And you can see after the 4th dose against BA.5, lots of neutralizing antibodies against wild type, but a substantial number of residents who don't have detectable antibodies against BA.5. Yes.
And Sharon, in our cohort, there were 2% of the older population that didn't develop antibodies after the 2nd dose, and that decreased to 7% with time. So yes, people's levels can drop off. The other side of that, however, we don't know that 0 antibodies means no protection, and that there are other parts of the immune system and other things that can contribute to fighting the infection. But clearly, people who do that, we recommend that they get their boosters.
Just wanted to add that it's also very much possible for antibody function, particularly neutralization function, to drop down to levels that are no longer detectable. So in addition to antibody levels. But again, we don't necessarily know that means that there's 0 protection, but boosters are important.
Perfect. Okay. Dr. Brumey, I'm going to keep you on the line there, and I'm going to ask the second question to you. Can we consider an infection like a booster? So if someone has had 3 doses, then got infected 3 months after the last dose, can they wait 3 months until their next dose? And does your answer differ if the next dose is a bivalent vaccine? So you got a lot of questions there, but try your best.
So the very short answer is yes, but just to be clear, we shouldn't be going out and trying to get COVID-19 just so that we can enjoy the benefits of hybrid immunity. I'm sorry if I didn't, that I should have made that clear. Dr. Costa said it much better. We should be absolutely trying to avoid getting COVID-19. But if unfortunately you get it, then you don't need to rush out right away to get your booster dose, even though it might have now been 6 months since your 3rd dose. It's too early to tell how maybe other groups have data on how quickly antibody levels will decline in the case of individuals who have had 3 doses and then COVID-19. Our data suggests that waiting 3 months should be absolutely fine and actually recommended. Probably waiting 3 months since the infection. Probably waiting even 6 months since that infection is probably still okay for younger adults. But perhaps there are other groups that have other data that would suggest. That would be my extrapolation from the data that we have.
As precisely or imprecisely as we can answer that, it conforms to exactly that. That's our assumption.
Yeah. And the second question is about, does the answer differ if the next dose is a bivalent vaccine or not? No, it wouldn't differ. In fact, going into the fall, my understanding is that bivalent boosters are being offered everywhere, and it makes sense. It makes sense to take the bivalent booster. I don't know if we want to. I see that question 4
Go ahead.
Also along that same lines, I don't know if we want to.
Yeah, why don't we jump into that one? I'm just going to ask this question because it relates to kind of the bivalent vaccine. I think the question that came in was, what is the value of the bivalent vaccine right now as opposed to univalent against Omicron, since the original strain is extinct? Happy for anybody to weigh in on that one.
I would say that the bivalent vaccines that include the now extinct strains are still very valuable, because the antibodies that you will generate, even against the original strain, will provide some cross protection against both existing Omicron variants and hopefully any Omicron variants that are still to come. So the bivalent gives you kind of the best of both that we have right now, and well, more practically speaking, there are no vaccines that are Omicron only.
I think we've gotten used to thinking about how influenza evolves and believing that that COVID is going to evolve in the same way. And interestingly, influenza evolves linearly. Okay, so you watch it go in one direction, and it doesn't take tangents, and it doesn't go back to the beginning. It just keeps moving. And so you always want to sort of catch up to it and be ahead. But COVID has not done that, right? SARS-CoV-2 new variants have come way in the back of the pack. And so we really don't know what's coming with SARS-CoV-2. As people keep telling me, when pi comes, pi could be some grandson of Omicron, but pi could also be the great-grandson of Wuhan and completely different from Omicron. So we really want to make sure that we're broadening our protection against what might be coming in the future, is one thing. But the second thing is that if you look at the difference in the antibodies you get and the protection you're likely to get between the ancestral vaccine and the Omicron boosters, there is a difference, but it's really small. Okay, so you get this much out of the ancestral booster, and then you get this much out of having an Omicron variant. So the benefit from these bivalent vaccines is present, but it's really not very big.
And to make the point extra, this is why being up to date on your vaccines is by far the most important consideration, not waiting for what you might presume to be, the better version.
And I think that was evidenced well. I think Dr. Costa in your study, and I think Dr. McGeer talked about it as well, is that getting these as soon as possible earlier in a wave is better. And I think now that people can get both their influenza vaccines and their bivalent boosters, et cetera, it's to remember that you can get them co-administered as well. So get them as soon as you can. I'm going to go to this next question here, and it's open to anybody, and I would welcome Dr. Satarangani to also comment in and where you feel comfortable. So in these serological studies, SARS-CoV-2 infection post-vaccination gives a better increase in antibody levels than just vaccination. So we've kind of answered a little bit of this before, but however, how does this compare to antibody levels from just infection alone?
So since you asked me to comment, I'll maybe go first. I think we've seen from the beginning, at least with the mRNA vaccines, the antibody levels that we're getting from 2 doses, even 2 doses of vaccine, is far greater than that from infection. And I think we've seen that and what we've seen from all of the studies that you've seen today is that the boosters give you more antibody even beyond the first 2 doses. And so I think, going back to some of the points that you mentioned, we would expect, we still don't have that correlate of protection. We don't know. We don't think antibody in itself is the only method by which people can be protected. We don't know how much antibody any person needs, and it may be different in different populations and different against different variants. But we do think that antibody is very important, and so more is certainly going to be going to be mostly better for most people. And so I think that is reflected in those comments that you and others have made, that the short-term protection we get from an infection versus the longer-term protection that we're seeing from vaccination, I think, and part of that is the higher antibody levels that we get from the mRNA vaccines.
Any other thoughts on that question?
Yeah, just to second that, vaccine-induced antibodies are better. We did have a minority of our participants who had already had COVID-19 prior to vaccines becoming available, and although most of them had some antibodies, neutralization was essentially negative, undetectable in nearly every person who was a convalescent individual. So two doses will give you much better antibody response than what you would expect from infection alone.
Terrific. I'm going to go to this next question that we have. This is actually directed to Dr. McGeer, but anybody else is welcome to comment. The question says, you said 50% of your long-term care home sample have not yet been infected with COVID. Is it possible that they have been infected but asymptomatic and weren't detected? And in brackets, they were asking, could anti-N levels have rapidly fallen and you didn't detect it?
So that's an excellent question, because anti-N levels do decline over time and you can miss people. So there will likely be a few people who were infected, particularly in the first wave. Remember how short of testing we were in the first wave, and in Ontario long-term care homes, we were not testing for the whole of outbreaks. However, we also know that in the great majority, 22 out of 25 residents who had proven COVID had antibody levels, and we did have 5 residents who came through that who were diagnosed by serology. Not in that graph, because of course we don't know when they got infected. We can't put a time on it, but we do know that they were infected. Since then, we've been following, and there are a small number of residents whose diagnosis has been based on anti-nuclear protein antibody when they get a test done, but it's a very small number, and that of course reflects the fact that there's a lot of testing going on in long-term care homes because we're so worried about detecting outbreaks early and implementing precautions. So I think in the community, there's been many more infections that don't get diagnosed, but in long-term care, because of all the screening that goes on and the testing, there's a much smaller number that are missed.
But that being said, you know, we've been watching nucleoprotein every 3 months, and the vast majority of people who have developed that have had symptoms. And during our rapid antigen test, only 3% of people who did not report symptoms had a NP in that 6-week prospective trial. So to get, again, a feature, but again, the behavioral part is a variable there.
And I think it's a good message that we were hearing about that, again, the number of folks or the percentage in Dr. McGeer's study that were not infected. Dr. Costa, were you seeing kind of, again, a similar good news story there that that we've been doing, relatively well in some cases in terms of helping to protect vulnerable residents?
Yeah, good news or bad news, I don't know. I always think less is certainly better, but I think we have a similar statistic gathered in a similar way. Our PCR confirmed cases are similar to our anti-N cases, and we've been picking up anti-N until recently as well. I think in our case, it's pretty home dependent. There are some homes that have always had a very, very low number of infections, and others that have infections quite frequently. And so that's part of the picture as well. You wouldn't expect to be in a nursing home or a retirement home and see 50% and assume it's the case. It's pretty home dependent, and that should be kept in mind as well, which suggests that, there are community factors that play in. Those are really important. They're very tough to change, but there's also other factors that we can probably influence over time.
And I just want to point out that if you think that by looking at the nursing home, you can tell that? The answer is you cannot. One of our nursing homes is a Class C facility with 4 bedrooms. It was on my list at the beginning of the pandemic as this home is going to have catastrophic outbreaks, and they have not. And I don't know, they're nice people and they work very well, but I really don't understand. There are some large new facilities that you would think would do well that have not done well. And there are some old, very crowded facilities that have not done well. And it remains, as Andrew said, it's still a little bit mysterious what it is that sets homes up for different levels of risk, because some of them seem to be predictable, but they're not, it hasn't panned out the way I think any of us thought it was going to.
Perfect. I'm now going to try and do some rapid fire, just because we have so many great questions that have come in. I'm just going to see if we can just get the person who wants to answer each of the questions I can get through in the next about 5 minutes. But of course, these are not simple questions, so we'll do our best. So it seems that this next question, it seems that blood IgG levels against SARS-CoV-2 spike protein, RBD, or whole spike protein were monitored in most of the presented studies, and it seems that dried blood samples were used. Did any of these studies evaluate IgA or IgM levels in saliva or nasal swabs, since this would be more indicative of antibodies that would prevent initial infection?
So Sharon, we didn't yet, but we are starting to. So that's the next phase of our study, is we're going to look at nasal IgG and IgA and look at hybrid immunity in that setting.
Perfect. Anyone else?
We've done some, and interestingly, IgA in serum, but not IgA in saliva, seem to correlate better with protection. So there's an assumption that if you get mucosal protection, that it will protect you. That's actually not true for other respiratory viruses, and so the jury's still out. But it's a really good idea, and I'm glad Sharon, at least, I'm sure there's some other people too working on salivary and nasal antibodies now.
Perfect. Okay, I'm going to go to this next question. This is open to anybody as well. Why is it that there is such a strong emphasis on monitoring neutralizing antibodies that target the spike RBD to evaluate immunizing protection? Should the binding of antibodies to anywhere on the spike protein not result in recognition as SARS-CoV-2 by the innate immune system cells?
So when we talk about neutralizing antibodies, we're not talking about antibodies where we know they bind. We're talking about antibodies that kill the virus. So when you do a virus neutralization assay, you're looking for viral death, and that could occur because you're impeding attachment to the cells. It might also occur because binding recruits complement. It's neutralization is not actually to a particular area. Having said that, it is true that the concentration of neutralizing antibody correlates well with regular binding to the receptor binding domains on the spike. So although they're not really that similar in terms of what they bind to necessarily, you do end up with about the same results either way you look.
Okay, I have another question here. Anyone care to opine on why BC's community dwelling seniors have higher seroprevalence than seniors living in long-term care? And they said in brackets, the turquoise boxes in Dr. Evans' slide number 16. They're saying, is it because there are fewer public health protections in BC's communities? I don't know, Dr. Evans, if you want to take a stab at that question.
No, I'll defer to Dr. Satarangani on that. But the one thing I would note is that we don't have the BC data is the most recent, and the data from the long-term care facilities is at least 2 or 3 months earlier. So it may be a temporal effect, but I'm sure Dr. Satarangani will have other observations.
And I think in addition to that, I think we have to be a little bit careful directly comparing data from different studies. They're all collected in a slightly different way. Some of them are using different assays to measure antibody, and there are we know there are some regional variations in terms of the infection rate as well. So I think that I take Dr. Evans' slide as more of a kind of big picture overview, and I think it's more difficult to just try and pick out specific points and make direct comparisons.
Thank you very much. I'm going to try with this one last question before I have to wrap up. How do you see the future of COVID-19 looking in terms of boosters for the foreseeable future? Let's just ask, do we think there'll be boosters for the foreseeable future? I do, for my opinion.
I think we can hope that we won't need boosters in January, but it's only hope, okay? I do think we're likely to need boosters come the beginning of next year sometime, and probably the fall after that. After that, in my mind, it's anybody's guess. I do think, I think you're looking at Dr. Walmsley's face and she's saying we're looking at boosters forever, and she's probably right. But there's nothing wrong with hoping that it might not be true.
Dr.
And
Walmsley?
I think just the final comment on that, I think that, or additional comment, I think that, going forward, it may also look very different. So there are formulations of COVID and flu vaccines being developed. There are pan-coronavirus vaccines being developed. So if we do end up in a situation where we need boosters forever, for example, then it may not look the same as it does now in the program.
I just think people should know that when we can't predict, but we can look back in science fairly well. And so, we can understand the real world efficacy fairly well of additional booster vaccines. And if we find that they're not effective, then it's unlikely that we'll continue. It's part of the picture.
But if we can keep people out of hospital and keep them well and don't let them die, it's not a big deal, right?
Absolutely. And I think what we've heard is a lot of good evidence today that there is something that we can do to protect ourselves this fall, and that's to get your bivalent booster and your flu vaccination. So that's something that we can all do for all of us who are watching. So this has been another great exchange of knowledge, but unfortunately, I need to use the time remaining on a very few brief announcements. First, it's my pleasure to thank all of our presenters today, Dr. Evans, Dr. Satarangani, Dr. Walmsley, Dr. Brumey, Dr. Costa, Dr. McGeer. Thank you all for your research, your expertise, and your time today. I'd of course like to thank all of our attendees as well. Your questions were amazing, and I'd like to thank you for sharing your time with us today, and I hope you enjoyed the seminar. So I'd like to say that the CITF team will be preparing a summary of this webinar and will make it available as usual on their website. They will also post a recording of the seminar in the coming days. The presentation is already on the website as a PDF in case you'd like to see it or share it. If you receive the CITF's weekly newsletter, you're going to get informed as to when everything is up on the page. If you don't receive their newsletter yet and you'd like to please go to the CITF's website homepage and sign up at the bottom. And finally, CITF's next seminar will be in November. They've asked 5 research groups focusing on people at higher risk of serious COVID-19 due to health conditions such as HIV, IMIDs, chronic kidney disease, patients and solid donor organ transplant recipients to share their latest research and data. Please stay tuned for more information. And again, you'll find details in the CITF newsletter, on their website, and on their social media pages. And here are the ways to get in touch with the CITF or to stay abreast of their news. I'll encourage you to follow them on social media as well. And again, thanks to everyone today, and thanks for joining us, and take care and have a great day.